Yes, Rohit.
Thank you, sir, for the opportunity. Sir, I would be talking about intraoperative floppy iris syndrome, decoding the missing link. I have nil financial disclosures relevant to the subject of my talk. Well, let's see this patient who got, flax done, and he's a patient on alpha-1 antagonist drugs. So I created the incision, and the moment I put in some amount of hair, the iris started coming out. So this was something which was there because the patient had been using these alpha-1 antagonist drugs for donkey years. So a small narrow side port incision was created, and while I was trying to take out the uh, capsulotomy which was done, the iris again started coming out. So this is one condition which we face, and this is another situation whereas the patient is on alpha-1 antagonist drugs and the pupil has constricted and the iris has started coming out through the primary incision. Another scene wherein, the pupil has constricted, the iris has started prolapsing through the side port incision. This was preoperative situation, and this was when intraoperative floppy iris syndrome was at its full blown picture. So this is another situation wherein you are trying to put in visco and the iris starts prolapsing. And another situation wherein when you are trying to do hydrodissection, you end up with an iris prolapse. So these are some situations, not to forget this last condition, in which, when you are trying to take out the phaco tip, so that it comes out. This is courtesy Dr. Pradeep Mohante. So I would like to acknowledge the work of David Chang in, discovering the intraoperative floppy iris syndrome, which is associated with iris billowing, progressive constriction of pupil, and the tendency to iris prolapse. Well, let's realize what all is happening in patients who are on alpha-1 antagonist drugs. We have to realize that there's a blockage of alpha-1A adrenergic receptors present in the dilator muscle of iris. Now, what does that cause? It causes a reduced maximum pupillary diameter. What else does it cause? There's a change in the dilator muscle region in these patients, and it is thinned out and atrophic. Now, what happens is that with this change in the iris structure, whenever you will find there is a fluid which has access to the posterior aspect of the iris, there is billowing of the iris and undulation. So when this happens, this is the first stage which can cause intraoperative floppy iris syndrome. So the first and foremost pearl which we have to bear in mind is that we have to give these patients adequate time to dilate, and the use of parasympatholytic drugs in the form of atropine. Some people start it even a day prior to the surgery. Tropicamide, NSAI drugs, and sympathomimetic drops can be used in cohesion with tropicamide too, but then there are certain contraindications in these compromised patients of the use of sympathomimetic drops. So let's understand the dynamics of iris trauma in normal patients. So what happens in these patients is that the pupil is dilated with mydriatics, have a strong dilator muscle action, as you can see. So whenever there is a trauma to the iris, it causes minimal pupillary constriction because the dilator tone is very much and it overpowers the constricting one. Pupil still doesn't constrict with repeated ones. However, with repeated iris trauma, now the constrictor tone overcomes the dilator tone and there's a pupillary constriction. But this is different in patients who are on alpha-1 antagonist drugs. So there's an exaggerated response to iris touch in these patients. So what happens now is that the dilator tone is less. A small trauma causes pupillary constriction. So this is something which we have to bear in mind. So the pupil and iris challenges in patients on alpha-1 antagonist drugs are, first, there's a smaller size of pupil. You have to realize that the thin muscle and dilator muscle region causes undulation and billowing. We have to give these patients adequate time to dilate. And the most important part of the whole story is that there is an exaggerated response to iris touch. Subsequently, we have to create a situation in which there is minimal iris trauma in these patients who are on alpha-1 antagonist drugs. It has been seen that patients who are on 7 millimeter or size or smaller pupil, the risk of IFIS is there, as has been shown by Alessandro et al. And our own David Chang has shown that even with a dilated 6 millimeter pupil diameter with Malugin ring, there was no significant intraoperative complications, despite the fact that 93% of the patients had moderate to severe IFIS. So this is something which we have to bear in mind. So now what is the surgical technique which we have to employ? In these patients, in this blue-eyed patient, and this patient who is on alpha-1 antagonist drug, the first and foremost thing which you have to do is you have to create a long and narrow anterior incision. That is the first thing which we have to do. A long and narrow incision. Definitely do not try to have a short tunnel or a posterior tunnel. You have to use intracameral epinephrine, despite the fact that in those patients who have been on these drugs for a long time, there is atrophy of the dilator tone. So use of viscoelastic, I'm using dispersive one in the form of HPMC, but Steve Arshinov has shown this is the narrow side port incision. A capsulorhexis sizing is very important in these patients. This is only one condition where the size of the rhexis should definitely be smaller than the size of the pupil. Mark my words, it has to be smaller. When you are doing hydrodissection, it should not be an exaggerated hydrodissection, because it itself can cause an iris prolapse. So this is another important thing. Low fluidics have to be used. A small nudge is all that is required, because otherwise when you go in, it can. Irrigation off when you go in. That is the next thing which you have to bear in mind. And if you see the fluidics are on the low side. It is 28 IOP. The basic concept is that there should be less turbulence of fluid in the anterior chamber, so which will help in preventing intraoperative floppy iris syndrome in these patients who are predisposed to or who are on alpha-1 antagonist drugs. So this is one thing which we have to bear in mind. And once you are done with it, with these low fluidics, the irrigation off, and you have to take out the phaco tip. Next is that the preferred technique to do is what you call a bimanual one, or you can retract it to do that. So I have 2 minutes with me.
Yes.
Yeah. So or you can do a coaxial one with a retracted sleeve. So what is the missing link in these patients? The missing link in these patients is, which we published in Clinical Ophthalmology, is the use of narrow calibrated side port technique to prevent occurrence of intraoperative floppy iris syndrome. So let's see, and this was already published way back in 2019 in the ARVO journal. So let's see how does this calibrated side port incision do. So what it does is, here it is. This is a blue-eyed patient. You will find when I'm using a calibrated side port instrument with the calibrated side port incision, there is minimal iris trauma at the side port incision, and with this calibrated side port incision, the maneuverability is possible. So there is no distortion of wound whatsoever in all these patients who are predisposed. And so in other words, what I'm trying to put across is, with all this, what is happening is that the side port incision, there is no iris touch, and it is not the cause of precipitation of intraoperative floppy iris syndrome from the side port incision. So this is something which has always been overlooked, and the one question which I would like you to ask after this is, these are the two videos of these two blue-eyed patients in which the size of the pupil was the same as it was at the start of the surgery. So my question is, how many of us are really calibrating the side port incision? Oh, great. And so this is very important, because this is just like a stepchild or whatever you want to say. You are not bothered about the side port incision. In our technique, what I'm doing is I'm using a narrow calibrated side port incision, which has a 500 micron side port incision. So 500 micron is the diameter of that. And the chopper which I'm using is 350 to 400 micron. So this variability gives the situation in which you can have maneuverability. So this is something which should be incorporated in our practice. Basically, all surgeries, whenever you are doing, you at the start of the surgery, you should see what the size of the pupil is and what the size of the pupil is at the end of the surgery. And if by any means the pupil comes down, then you have to bear in mind that you have been traumatic to the iris. So this is something which should be borne in mind. And what does it add? So it adds, when you add it to the existing protocols, it increases the efficacy in preventing IFIS. So if you are using bimanual, create a small calibrated incision, and when you are done with the phaco part, then you can increase the size of the the side ports to do irrigation aspiration. So I would like to acknowledge the works of David Chang, Campbell, Steve Arshinoff, and Richard Packard in it. Thank you very much for your kind attention.
Thank you, Rohit. Always a very good